So we'll start. The first topic is by Dr. Janie Joseph, and she is working as a glaucoma consultant at Amala Medical College, and she will be speaking on ASOCT or UBM, the which and the why. Over to you.
Very good afternoon to all. At the outset, I would like to thank KSOS and Dr. Jayasri for giving me this opportunity. My role is actually to introduce the two devices, ASOCT and UBM, and their specific indications. So I have no any financial disclosures. So when I search the literature, actually there are so much literature articles regarding which and when to use. And actually, it's not a big debate to think about which device to use and when, because both are actually acting with different mechanism and both are having different indications, both are having different uses. So it's not a big debate. You should know the proper condition and you should use it properly. So both ASOCT and UBM are non-invasive imaging devices which gives the high resolution cross-sectional images of the anterior segment of the eye. So regarding UBM, it is mainly uses the high frequency ultrasound, and it actually requires a water cup bath setup. There, whether it's a liquid media should be there between the probe and the eye, and hence it takes more faster. It takes a longer time to acquire the images, and it is usually a trained technician is required for its operation. But the unique feature of this UBM when compared to the ASOCT is that it can capture through the opaque media, the opaque cornea, and we can visualize the structures behind the iris and the ciliary body, which is not visualized by the ASOCT. Whereas ASOCT is using the light waves and it acts on the principle of low coherence interferometry. And it is a non-contact technique, and it gives us faster acquisition of the images. But the problem with ASOCT is that it requires a clear media and we can't visualize the structures posterior to the iris pigment epithelium. So when should I go for a UBM? The first thing is when the cornea is hazy, I have no other options, it is only UBM. Like conditions in which there's the corneal opacity, a case of congenital glaucoma or a Peters anomaly, where UBM will help us it may reveal the presence of any associated aniridia or a congenital aphakia, and it may also help in the proper surgical decisions in the management of those patients. So it's the imaging modality of choice is UBM. If you want to visualize the structures behind the iris and the ciliary body, the imaging modality of choice is UBM. The thing is that if I can use an ASOCT to find out whether the angle is open or not. But still again, if I want to know the mechanism of the angle closure, or if I want to rule out the plateau iris, I should go for a UBM. Because the plateau iris is mainly due to the rotation of the anterior ciliary processes, and I should see whether the ciliary sulcus is present or not. In those cases, UBM will help us. Also in conditions like pseudo-plateau iris, in which where the iris cyst or can be due to secondary or iridociliary tumors, which can cause pseudo-plateau iris, those mechanisms also will be relieved by the UBM. Then to visualize the zonules and the peripheral lens, as in case of post-op patients in which the patient comes with recurrent redness and pain, uveitis, in those cases we can look for the malpositioned IOLs and the presence of CTR, the positioning of CTR with the lens, all can be evaluated by the UBM. Also in evaluation of phakic IOL patients, UBM also plays an important role. Then in case of malignant glaucoma, the anterotated ciliary body can be well visualized with the UBM. In conditions in which a young patient can present with an acute onset transient myopia with bilateral angle closure, which can be due to drug-induced, the supraciliary effusion can be well visualized with this UBM. Also in post-traumatic cases and in post-op, post-trabeculectomy, the ciliocoroidal detachments, post-laser, all is better visualized with the UBM. But in patients with anterior segment trauma or a suspected case of open globe injury and all, the imaging modality of choice will be ASOCT, because immediately post-op bleb assessment is all better with this non-contact technique of ASOCT. And the positioning of the glaucoma drainage devices all can be immediately assessed by ASOCT due to its non-contact nature. But still, post-traumatic, still the patient is having prolonged hypotony and all. We can assess the presence of cyclodialysis cleft. It is done by it gives seen only by the UBM. Also, the presence of angle recession can be clearly assessed by UBM. But if we are sitting at an OPD, yes, you want to go for a routine, quick angle assessment. We have no trained technician is not there, or the patient is slightly uncooperative. Better go for an easier technique like an ASOCT. The other advantages of this ASOCT is that the non-pigmented tumors are better visualized by the ASOCT. Also, in case of this OSSN, the intralesional details can be better evaluated by ASOCT, and the proper management can be decided by it. Whereas UBM plays an important role in pigmented tumors, and the delineation of the posterior margin is better visualized by UBM. So the ASOCT is a non-invasive, non-contact. Other one is the contact method. The ease of operation, better, easily done. ASOCT, other one requires a trained personnel. ASOCT can be done in a sitting posture. UBM, initially supine, but now it is available. The patient can be done in a sitting posture. But the thing is that in anterior segment, only till the iris pigment epithelium is visualized in ASOCT, whereas in UBM, everything posteriorly can be visualized till the iridocerebellar complex can be visualized. Both has its own limitations, no view in opaque cornea, and the scleral spur definition problem is still there in ASOCT. UBM, again the risk of infection, corneal abrasion due to its contact nature, and is contraindicated in suspected open globe injuries. So I will conclude it that actually the other sections will enlighten you about more about these devices. So my conclusion is that both complement each other, each has its own uses and its own limitations, but still the dynamic indentation gonioscopy is still our clinical reference standard method, and these tools and all will augment our practice and helps in research. Thank you.
Thank you, Dr. Jaini, for highlighting the situations where you can use UBM and ASOCT. Next, on to Dr. Sandhya ma'am. She is currently the professor at Calicut Medical College, and she will be speaking on the role of anterior segment OCT.
Good evening all. Now we'll just discuss about some details of anterior segment OCT in angle closure glaucoma. So these are the commercially available ASOCT machines. The earlier time domain, now Fourier, and latest is ultra high resolution ASOCT. Now what are the advantages of ASOCT when compared to gonioscopy? It is easier to use, as Dr. Jaini described. In a busy OPD, it will be difficult to do a gonioscopy. So you can easily use it. It is non-operator dependent. Objective measurements of the angle parameters are possible. New risk factors for angle closure glaucoma like anterior chamber area, volume, and lens vault has been found out by this method. And it can also measure the iris parameters like iris thickness, area, curvature, and volume. Patency of laser PI can be made, but that is even possible even with slit lamp. Then accurate and reproducible measurements of peripheral anterior synecdoche is also possible. Disadvantage. The main problem, as described earlier, is identification of scleral spur, which can affect the quantitative measurements because all the measurements are based on scleral spur identification. Then again, it cannot visualize structures posterior to iris pigment epithelium. That is again, then it cannot differentiate between appositional and synechial angle closure, which is possible with your gonioscopy. Then it cannot find out other findings like pseudoexfoliation, neovascularization, etc., which is possible only with your gonioscopic examination. And 360-degree view of angle is not possible, but with newer ones, I think it is possible. There are various quantitative measurements in ASOCT. These are the angle parameters, anterior chamber parameters, iris parameters, pupillary diameter, and lens vault. Angle parameters are angle opening distance, trabecular iris space area, trabecular iris angle, and angle recess area. Actually, these angle parameters are not used nowadays. Among the quantitative, the anterior chamber parameters, iris parameters, pupillary diameter and lens vault is important, and among them lens vault is the most important parameter which is used nowadays. Now, as I said earlier, identification of scleral spur is the most important step in the ASOCT interpretation. So how can you identify scleral spur? There are three different methods. Actually, scleral spur is defined as described as a point where there is a change in curvature of the inner surface of the angle wall, often appearing as an inward protrusion of the sclera. You can see that inward protrusion of the sclera, that is defined as the scleral spur. So what are the three methods? You have three methods. One is, as we described earlier, that is the bump in the inner corneal meshwork margin, this projection. Next is, you can identify the Schwalbe's line, which is the termination of the Descemet's membrane, and from there around 700 to 1000 microns is the scleral spur. And another method is intersection of ciliary muscle and the inner corneal margin. This hyporeflective area, this is the ciliary muscle. So here you can see the intersection of the ciliary muscle and the inner corneal margin. This is the scleral spur. So the most common what we use is a bump in the inner corneal meshwork margin. But there is one study which compares these three methods which show that this is the more realistic one. Now these are the various anterior chamber parameters. This is not so important nowadays. This is the iris parameters, iris thickness, area and volume and curvature. Now these again, as we said earlier, the normative data we usually don't use. And basically, again, as we said, ASOCT, the main problem is identification of scleral spur. So in which all situations it is more difficult? It is difficult to visualize in closed angles. Here you can see the angles are closed. So it is very difficult to visualize the scleral spur. And another thing is, it is difficult to visualize in superior and inferior angles because of the effect of lid. Now, so actually they try to design newer parameters, other landmarks for this angle parameters. So they can, it is said that we can use Schwalbe's line as an identification. So all these angle opening distance, everything was based on scleral spur, but if Schwalbe's line is used, they say it is more reliable. But in most of the studies, even still now, scleral spur is used as the method. Now another thing which is recent now is BEL, that is band of extracanalicular limbal lamina. So what is BEL? It is a layer of connective tissue located around the Schlemm's canal, which is an important structure involved in draining the aqueous humor from the eye. So what is the importance of this BEL in ASOCT? Here this curved like hyperreflective structure, this is the BEL. And this one is the trabecular meshwork. And this is the yellow arrow is the trabecular meshwork and the red arrow is the Schlemm's canal. So this in one study it was shown that the outer border of BEL was identifiable in 95% of cases. So this can be used as a landmark for identifying trabecular meshwork. So that is BEL or band of extracanalicular limbal lamina. Now, reproducibility of quantitative parameters. Why these quantitative parameters are not used nowadays? Why? Because these are the reasons. That is, maybe due to variation in the pupil size and also error in marking scleral spur, because all the quantitative parameters are based on identification of scleral spur. So if you go wrong in marking the scleral spur, all your parameters will be wrong. So, but the anterior chamber parameters, they have got better reproducibility, that is anterior chamber depth, width and volume. Now, qualitative is the most common, qualitative parameters are more commonly used in ASOCT. So actually, first important step, whenever you analyze an ASOCT, the first step is you have to identify the scleral spur. So here, as I said, it is very difficult to identify scleral spur in this image. But you can identify this hyperreflective area, that is the BEL. And this is the trabecular meshwork. So you can see the iris is in contact with the trabecular meshwork. So there is iridotrabecular contact in this ASOCT. Whereas here you can see this is a hyperreflective area. Here you can see the scleral spur, which is a projection, right? So as we said earlier, scleral spur is very difficult to identify in closed angles. But in open angles, you can clearly identify the scleral spur. So here is the trabecular meshwork, here is the bell. So here you can see it is a wide open angle. There is no iridotrabecular contact. Again here this is the bell and this is the trabecular meshwork. This is also not so open, but still there is no iridotrabecular contact. But this is a wide open angle. This can be considered as open. This is iridotrabecular contact. This is how usually we analyze in ASOCT. So here this is a closed angle. So post PI you can see that the angle has slightly opened up. So that is the importance of ASOCT. In ASOCT you look for iridotrabecular contact. Again this is closed. Here this is the bell. You can see the trabecular meshwork. There is iridotrabecular contact. Again this is open. This is the trabecular meshwork. This is the bell. It is open. Now while doing ASOCT, these things should be taken care of. That is, one is standardization of lighting conditions and retraction of lid. Here you can see one artifact. This is due to the lid. This black thing is an artifact which is due to the lid. And another thing is small changes in pupil size can have large effects on the angle width measured by ASOCT. That is why you have to maintain the lighting conditions. And inadequate retraction of lid can lead to attenuation of signal, which you can see here, and which makes it difficult. Suppose if this artifact was here, you won't be able to identify the scleral spur. Now there are some biometric risk factors for angle closure glaucoma. This is found in one study, that is static and dynamic risk factors. Static risk factors are all these, but among them they have found that lens vault, anterior chamber area and anterior chamber volume, they are associated with the higher odds for angle closure. That is, if the lens vault is more, if the anterior chamber area is less and the anterior chamber volume is also less, then there is a high chance for angle closure. Dynamic risk factors are larger and more peripherally distributed iris, less iris area loss per millimeter of pupillary distance, then change in centroid to centroid distance, etc. Then there is an ASOCT based subdivision of angle closure glaucoma. So this is important in actually managing a case of angle closure glaucoma. So this study showed that there are mainly 3 groups of patients based on ASOCT. One is those with thick peripheral iris. Here you can see the iris thickness. It is almost normal, but here you can see the iris thickness. Peripheral iris is more thicker. So there is one group with thicker peripheral iris, another group with large lens vault, which will be discussed by the next speaker, and the other one is mixed group. So according to the study, ASOCT based, there are 3 groups, one with thicker iris, one with increased lens vault, and the other is mixed group. Then there are different PAC mechanisms, again based on ASOCT. One is your classical pupillary block. How will you identify pupillary block in ASOCT? Here you can see the classic convex iris configuration. Convex iris configuration with deep central anterior chamber depth. So this is the classical pupillary block. Next is the plateau iris configuration. How will you identify? Actually, it is better diagnosed with UBM as discussed by Dr. Jaini. But here you can see that the iris is slightly anterior. And here, as we said earlier, this is the thicker peripheral iris. And here you can see the exaggerated lens vault. So these are the different PAC mechanisms according to the ASOCT. So among the study, it was noted that the mechanism of angle closure glaucoma differed significantly between fellow eyes of acute angle closure, eyes with PACG and eyes with PACS. While pupillary block was the main dominant mechanism in majority of the fellow and PACS eyes, only 48.7% of PACG eyes had pupillary block. That means acute angle closure glaucoma, main mechanism is pupillary block. But when they go to that chronic phase, the mechanism is different, not always pupillary block. And PACG eyes, chronic glaucoma eyes, have relatively higher proportions of exaggerated lens vault and plateau iris as dominant mechanism. So it is said that non-pupillary block mechanisms such as angle crowding, secondary to thick iris and anteriorly directed iris or an anteriorly displaced lens plays important role in developing chronic disease, while pupillary block is the dominant mechanism in acute angle closure. So they say this PI helps more in acute angle closure patients. Whereas since the mechanism is others are like thick peripheral iris and lens fault, PA may not always help in such cases. But definitely, as we know, gonioscopy is the gold standard. But there are some things which we can, which ASOCT is more helpful, like as we told, lens fault and dissolve, more evident with this ASOCT. And it is that those with increased lens fault may help with lens extraction. Okay. Thank you.
Thank you, Dr. Sandhya. Now we have Dr. Jayashree. She will be highlighting about the role of ultrasound biomicroscopy. She is a chief consultant at iVision Eye Hospital, Thrissur.
So the talk on ASOCT was very illustrative and very useful. And coming to comparison between UBM, I thought UBM was also interesting topic. Hope actually those people also have gone. So we'll start off. Okay. so anyway. So what is basically UBM? UBM again is a imaging technique, high resolution ultrasound technique. It is non-invasive in vivo imaging. So it is like a, it gives near light microscopic level of imaging clarity. So UBM was developed by Pavlin, Scherer and Foster. It was in the late 1980s only it was developed. So this is how the UBM looks like. It has a probe, a screen, and it is done with a water immersion. So it has silicone cups, and this is how the between the B scan and the UBM, the frequency is different. It is like with high frequency when compared to a B scan, and hence because of the high frequency, the depth of penetration is just 4 to 5 millimeter, and you are able to image only that much of depth. The principle is similar to the B scan imaging. High frequency transducer is made, which is made of piezoelectric polymer, is moved linearly over the imaging field, and the transducer transforms the electrical energy into acoustic energy and vice versa. So this is how the parts are there. This is the water bath, water immersion that is used, which is kept onto the eye like this, and onto this, after filling the water, this transducer is kept and imaging is done. And this is how the image looks like. So we have transverse cut and the radial sections. Radial section is when you keep, when the patient looks directly onto the ceiling and you keep the UBM probe onto the cornea. When it is 3 o'clock to 6 o'clock, you get like this, and 12 o'clock to 6 o'clock you keep, and then many clock hours you can keep. You have at the end of the probe one white marking, and this white marking will be onto the image on the side will be onto the right side of the screen. Here the right side of the screen will be the white mark, and when the transverse imaging is onto the limbus. So when you keep the probe onto the limbus, the transverse image happens, and transverse image is usually to identify the ciliary process and beyond. So the probe orientation is the white mark will be on the right side. Normal ocular structures needs to be identified, as Dr. Jaini has correctly mentioned. The identification of the structures posterior to the pigmented iris layer is what is most important in UBM. This is what is most crucial in identifying secondary angle closure. That is where UBM is most important. We can identify that the angle is closed. For that, ASOCT may not be required. We can identify otherwise also. But what is the reason for this secondary angle closure? When you need to identify that, you need to see what the ciliary body is, what is the relation of the posterior chamber, what is the relation of the lens and the iris, and how is the ciliary body and the choroid acting. So that can be identified based on this. So we are able to not just identify glaucoma. It is useful in tumors, traumas, identifying scleral structure, sclera, layers of sclera, cornea. in identification of ICL and identification of placing of the IOL and ocular adnexa assessment also. So, what is the some role of UBM is there also in open angle glaucoma? Even if I have told mostly in the secondary angle closure, the UBM is useful predominantly in pigmentary glaucoma. We know that pigmentary glaucoma has reverse pupillary block. Because of this posterior bowing, what happens is these zonules can be clearly seen in UBM. These zonules will rub against the posterior aspect of the iris, and this releases the pigments, and PI definitely helps in this pigmentary glaucoma. So at least in the before that severe pressure increases happens, if you do a PI, this reverse pupillary block goes off and the patients are relieved of pupillary block, reverse pupillary block, and it is the treatment. So it definitely helps and you can do it. And when IOL is in the sulcus and the haptic rub, that is when one piece IOL is kept in the sulcus and not in the bag, this haptic can rub against the posterior iris pigments and release pigments, and this can lead to what is called UGH syndrome also. So if the pigments are there and the pressure is not coming down, you can always look at the relation, and if you see this, you have to take the IOL or dial back into the, if it is an early case, you can dial back. Closed angle glaucoma, all the types of pupillary block can be identified, plateau iris can be identified, anterior synechia, ciliochoroidal effusion, malignant glaucoma. To identify malignant glaucoma, you need to have an UBM and cystic angle closure. So this is a condition of phakic pupillary block. What are the things that you can make out in this case? So I'll suggest something. This is a anteriorly subluxated lens. What else is there? Anything peculiar with the lens? It is a microspherophakia. Can you make out? The lens is spherical. The lens is small. So it is a microspherophakia. What about the zonule? Do you see a wavy nature of the zonule? The zonule is weak and some areas it is broken. So it has a broken zonule, and that is the reason it has anteriorly subluxated. So doing a PA, it will fall back. Okay, this is what pseudophakic pupillary block. And how do you this patient was referred 6 weeks after cataract surgery with severe pain, headache, vomiting and all, and referred as a malignant glaucoma. So the treatment, I mean, in malignant glaucoma also you end up doing a PI and try to hit the posterior aspect and hit the hyaloidotomy, trying through the PI only with the laser initially. But even then, the treatment may not be sufficient with malignant glaucoma, sufficient at that point of time. But how do you differentiate it? By UBM alone. This here is one crucial step is there to identify whether it is pseudophakic pupillary block or malignant glaucoma. This is this angle, the pupil and the iris ciliary body angle. If this angle is maintained, it is always pseudophakic pupillary block. If this angle is not maintained, it is malignant glaucoma. Always look for this angle, and that is the catch point, nothing else. And doing a PA, immediately this falls back, all the pressure, you don't have to give any other medicine. Take the patient immediately to the PA, the pain is relieved. This is plateau iris configuration. What you see, closed angle and the ciliary body is apposition. But this patient is not in pain or not in an emergency, because this is a normal case coming with an angle closure. So, why this PI? When you do PI in plateau iris, it is not going back because the posterior iris is supported by the anteriorly rotated ciliary body. So, it is never going to fall back. What helps in plateau iris is the peripheral iris constriction by iridoplasty. This is an anterior synechia. So secondary angle closure, Dr. Jaini has mentioned, no? So you can see the secondary angle closure, angle is closed and ciliary body effusion. And when you do the transverse section as told, no, that from the limbus, if you recede back, what you see is like this much of choroidal effusion. That patchy sponge-like area you are able to make out, no? That is the choroidal effusion. So once you stop that inciting drug, all this goes off. Let me just tell you one thing. The most important sign or most important thing that should give you the diagnosis of a secondary angle closure is the myopic shift. If nothing else is also there, nothing else is there, if the myopic shift is there, that is sufficient to make a diagnosis of drug-induced secondary angle closure, the drug-induced thing. And this is at presentation where you can see this is closed, and here again the ciliary sulcus is not there, choroidal effusion is there. So once the treatment is over, what you can see is that the angle has opened up, and at one point you can make out that ciliary sulcus would have come and the choroidal effusion has gone off. One of the maybe and malignant glaucoma, as I'll show the picture directly. This is how a malignant glaucoma looks like. Again, the AC is very shallow. Usually in malignant glaucoma, even the center portion becomes very shallow, and you cannot identify the ciliary body as a separate structure, even because it is the posterior pushing from the vitreous. And the ciliary body also goes and gets plastered onto the iris, and everything as a whole unit goes and gets plastered onto the cornea. So this is a case where exudation has happened in the iris, and this is an endophthalmitis, endogenous endophthalmitis, and on treatment this iris exudate has cleared. So in trauma, what is this? This is a case of iridodialysis. The iris has come from the iris root has given off. So why is this iris root gives off after trauma? It is because it is the thinnest area near the root. There will be a small stump which is remaining at the scleral spur. So this is again angle recession. Angle recession is where the both layers separates, and this is how the schematic diagram shows. Here this is the scleral spur, and this is the attachment of the ciliary body. And angle recession is like this. The two layers get separated. So here the two layers are separated. The ciliary body is still attached at the scleral spur. This is the normal one. This is what? This is cleft where it has detached. So you can see a cleft here, the gap. So that is the cyclodialysis cleft. So it is important to identifying the anterior portion of the cyclodialysis cleft is possible in ASOCT. If you move the eye and take the ASOCT, you can see some extent of the cyclodialysis cleft in ASOCT. But it is important to do the UBM in cyclodialysis cleft, because it is very important to identify the extent of cyclodialysis cleft, also to see the effusion, the fluid that is there. Sometimes what happens, gonioscopy also might be little dicey, in the sense like the anterior portions, some portion will be covered with PAS, and behind that cyclodialysis will be there. So it is very important to do an UBM, especially post-trauma if you have hypotony, even post-surgery also. So to see the extent of iris cyst, here whether the iris cyst is extending onto the ciliary body also can be seen. Evaluation of bleb morphology. Ideally, bleb morphology is not done with UBM. It is best done with the ASOCT, because ASOCT you don't have to have a contact method, and the details, the resolution is always better with an ASOCT than the UBM. So the perfect details will be seen on the ASOCT, and you don't have to touch. We are always worried about touching the bleb. And immediate post-op also you can do the ASOCT on a ASOCT bleb. Again, post AGV, the same thing. Here the AGV, it is a opaque cornea. So here the ASOCT may not be that useful, but even if you say ASOCT is done in clear cornea, some amount of opacity the ASOCT gets through. And here what you see is the valve is not reaching onto the tube is not reaching onto the anterior chamber, and that is the reason why the pressure might be elevated. This one is already highlighted the difference. The most and the important difference is the visualization behind the pigment epithelium. And the most other limitation, the lying position cannot be done, and this contact procedure and contamination risk, everything can be reduced by using what is called as a clear scan. Clear scan is a fluid filled chamber that can be attached onto the UBM probe. So the patient need not always be made to lie down. You need not use the same probe. You can cover the probe, so the risk of contamination will be way less when you use the clear scan. But it costs around 1000 rupees for that clear scan cover itself. So these are the textbook you can refer. And thank you. Hope it was useful. Next, over to Dr. Anjana. She is a glaucoma consultant. One more topic is there, madam. Please sit. And it is the topic is on lens assessment and bleb assessment with ASOCT.
Hello. So,
Let them enjoy.
so good evening. I'll try to make it as short and sweet as possible. So my topic is, first of all, at the outset, let me thank KSOS and Dr. Jayashree for giving me this opportunity. At least I read through a lot and understood a lot about this. So I'll be dealing with the lens and bleb assessment and what else we will see as we go through. So most of the differences have been highlighted, and one thing which is pupil size is less affected by ASOCT than with UBM, and some of the important limitations about ASOCT which we need to take care is that the operator should be aware about the scan protocols and the instrumentation. Why the image is taken, they should be aware of it. Then only they can acquire a proper image. So even though it's easy, the operator should know what to take, when to take, in which position, which scan protocol to use and all to get a proper image. And the tracking between visits is found to be not very good with ASOCT, and the interpretation by the doctors also, the landmarks and all may differ sometimes. And the UBM, as already mentioned, has the advantage of penetrating the posterior pigment epithelium. In the lens assessment, the two terms which need to be known is, one is crystalline lens rise and the other one is lens vault. And as mentioned, lens vault is associated with angle closure. So I'll show this, like in the first picture, it's the angle recess to angle recess line is drawn, and the perpendicular from there to the anterior crystalline surface of the lens is the clear crystalline lens rise. And this is more used for planning phakic IOLs and all. And the second one, it's the scleral spur to scleral spur line, and the perpendicular from there to the anterior crystalline surface is the lens vault. So scleral spur, we have Dr. Sandhya has given the details about how to identify, and so it is the prominent inward extension of the sclera with a change in curvature. And it is used as a reference point to identify trabecular meshwork and iris root and all. So these pictures, both of them show same lens vault. The scleral spur line has been aligned and the lens vault is almost the same, but as we can make out, the anterior chamber depth is different. The first one is a narrow, shallow AC, and the other one has a larger anterior chamber. So even though the lens vault is a predictor for angle closure, sometimes it may not give a correct result. So anterior vault is assessed, that is actually lens vault with anterior chamber depth, and the relative lens vault, which is the lens vault in relation to the anterior vault. The relative lens vault will give a better idea of the chances of angle closure than the lens vault. So this is a study of about 100 subjects, and you can see that both the lens vault and relative lens vault are more in PSC eyes, but relative lens vault is supposed to be more reliable than the lens vault assessment. And as already mentioned, the UBM only gives the detailed evaluation of the lens up to the posterior lens capsule, which is not possible with an ISOCT. Coming to the next, that is the bleb assessment, and as you all know, TRAB is the most effective surgical method till now worldwide, and we assess the bleb based on the bleb morphology, and the main cause of bleb failure is scarring. And there has been different grading system, like the MBGS grading system, which sees the diffusion area, bleb height, vascularity, subconjunctival blood and all. Then Indiana bleb grade appearance grading system, Wurzburg grading system and all. In all these grading systems, they use the photographic appearance and the slit lamp to assess the bleb. The internal architecture of the bleb is not taken care of, and as you know, it's not easy to just assess a bleb based on the external appearance alone. So in these cases, along with this grading system, if you also use an imaging technique to see the details, you will get a better assessment of the bleb. UBM, as already mentioned by Dr. Jaini, all of them, it's a contact method and not usually used for bleb, especially as it's a post-op cases. It has a 91% sensitivity for predicting functioning blebs and 70% sensitivity in non-functioning, predicting non-functioning blebs. But because of the contact method, it's not very commonly used. The ASOCT can be used to assess the bleb height, wall thickness, and outflow pathway. And as you can make out, the outflow pathway consists of the sclerotomy or the internal ostium, the root under the scleral flap, and then through the edges of the flap into the subconjunctival space, and from there it's filtered into the tears, through the veins, and into the posterior episcleral space. So in the first image, you can make out a sclerotomy. The second one, the root under the scleral flap is seen. Then there is some suprascleral fluid collection there. Then the subconjunctival fluid collection spaces are seen. And the next image is our own image, which also shows the root under the scleral flap and the subconjunctival and suprascleral fluid spaces. In case of cystic blebs, you can make out multiloculated fluid spaces. And the second one is an encapsulated bleb, where the bleb wall is having high reflectivity and no much of cystic spaces are seen. So it's not functioning properly. And a flattened bleb or a failed bleb, the difference in bleb elevation is difficult to evaluate, and there will be high reflectivity. The scleral reflectivity along with the bleb area will be almost the same. This we can hardly make out the edges of the scleral flap. So microcyst in the bleb wall helps in assessing the functionality. In this picture, I hope you can see multiple microcysts. And this is anteriorly, actually, the bleb was having a good morphology, while towards the posterior aspect, there was an encapsulation. And when you take it, you can see that the bleb wall is having a high reflectivity there, which shows at that area the diffusion is not that good. So if the IOP rises, we may consider needling in those cases. And this, though the image quality is not good, I hope you can make out the sclerotomy ostium. And multiple subconjunctival fluid spaces are highlighted in the next picture. So the bleb after surgery goes through an inflammation phase, then a proliferative phase, and extended remodeling phase, and it takes about 1 to 2 months for a bleb to mature. And the importance of imaging is that when you do it at the right time and detect these changes, it may help us to assess about the intervention following the trabeculectomy, whether a laser suture lysis or a mitomycin injection or a needling will help or not will be better evaluated using these imaging technologies rather than just by a slit lamp or a photographic method. For single parameters, it is a microcyst which shows a good functioning bleb, and other parameters, as already mentioned, will help. And as already been discussed, I'll just go through the slides first. The tube patency can be checked with ASOCT. Tube block, partially blocked in the first picture by an iris, and in the second picture, as already shown earlier by Dr. Jayashree, it's not entered into the anterior chamber. And even though the cornea is a bit hazy in this, and they suspected an endothelial touch of the tube, you can make out that the tube is not touching the endothelium. And as already mentioned, the UBM has a better penetration, and other uses are in opaque cornea. UBM has a better functional. The cyclodialysis cleft also has been mentioned, and I just wish to say that in this picture, the gonio may show a closed angle because the iris, as you can make out, not the ciliary body area, the iris is touching the scleral, and it may appear as closed. The scleral cleft, the cyclodialysis cleft may not be seen by the gonioscope. And malignant glaucoma, anterior rotation of the ciliary body can be seen. So plateau iris also has been mentioned, and I'll just rush through, and I think it also all have been covered. Thank you for your patient listening.
Just an announcement. I'm calling for the general body now in this hall, because there won't be any quorum, so we will start at 5:30. You please continue. This has to be. This is a formality. You please continue. No problem. You can, okay. Thank you.
Thank you, Dr. Anjana, for such an illustrative presentation. So we'll have question and answer section also.
Can we identify pigment dispersion, that concavity, using ASOCT? Pigment.
Definitely we can identify the concavity, but we cannot identify the sonular touch. If concavity is there and pigment dispersion is there, then it indicates sonular touch, and that is the reason for. So, if you the diagnostic sign is, if you pre-dilatation you check the IOP, post-dilatation if you check the IOP, if there is a drastic increase in IOP, it indicates a reason to do a PA. Okay, and also if you have an already, preferably before becoming a glaucoma, and in this post dilatation IOP spike, if you do the PI, that is when it is going to have maximum effect. ഗ്ലോക്കോമ ആവുന്നതിന് മുമ്പ് തന്നെ നമ്മൾ ഡയലേറ്റ് ചെയ്യുമ്പോൾ പ്രഷർ കൂടുകയാണെന്ന് കാണുമ്പോൾ ഇഫ് യു ഡു എ PI, ദാറ്റ് ഈസ് വെൻ ഇറ്റ് ഈസ് ഗോയിങ് ടു ആക്ട് ദ ബെസ്റ്റ്. ഇറ്റ്സ് നോട്ട് ലൈക്ക് എവറി PDS വിൽ നീഡ്, പക്ഷേ ഡയലേറ്റ് ചെയ്യുമ്പോൾ പ്രഷർ കൂടുന്ന PDSന് വേണ്ടി വരും. So thank you, madam. Thank you. Wind up.